Good afternoon, everyone. Welcome to our next edition of Chengai Pediatric Meet. Hope we can start if everyone is ready. The first presentation is from Sri Balaji Medical College and Hospital. Illusion of inflammation causing diagnostic delusion. To be or not to be. Presented by Dr. Raghuram Eluri and moderated by Dr. Sundari S, HOD and Professor, Department of Pediatrics, Sri Balaji Medical College. You can share your slides and start, please.
And before, at the outset, on behalf of IAP Chengalpattu, I welcome all the faculties, all head of departments from all the medical colleges, and also postgraduate students. Welcome for another edition for this month. Okay. So if everything is fine, we can start from Balaji Medical College.
Thank you, sir. Good morning, everyone. I am Dr. Raghuram from Balaji Medical College. I am going to discuss about a case of illusion of inflammation causing diagnostic delusion to be or not to be. A 9-year-old first-order male developmentally normal child born to a non-consanguineous marriage came with the chief complaints of swelling on right side for the past 6 months. Swelling was insidious in onset, gradually progressive, and not associated with pain. With no history of fever, weight loss, night sweats, difficulty in breathing, joint pains, rashes, bleeding manifestations, cough, abdominal pain, vomiting, and loose stools. Child was immunized according to national immunization schedule with nil significant family history and no history of contact with tuberculosis. On admission, child vitals are stable and anthropometry was appropriate to the age. On examination, no pallor, icterus, clubbing, cyanosis, and edema. On head-to-toe examination, 18 to 5 centimeters non-tender swelling on right side of the neck in jugular-digastric triangle appears to be lymph nodes. Bilateral superficial and posterior cervical lymph nodes of size 2 into 2 centimeters and right anterior cervical and right unilateral inguinal lymph node of size 2 into 2 centimeter non-tender form mated lymph nodes are present. On systemic examination, form smooth rounded spleen is palpable 4 centimeters under the left subcostal margin. Other systems examination was normal. Probable diagnosis was disseminated tuberculosis, lymphoma, sarcoidosis, infectious mononucleosis, HIV, and Lennart lymphoma. On investigations, CBC and peripheral smear showed eosinophilia with raised TSR, LFT, RFT chest X-ray was normal, and ultrasound neck shows multiple subcutaneous and enlarged lymph nodes mated together with preserved fatty hilum. Ultrasound abdomen shows splenomegaly and mesenteric lymphadenopathy. CT chest shows ground glass opacities, and CT abdomen shows splenomegaly with mesenteric and retroperitoneal lymphadenopathy. MAN2 was negative, sputum PPNAT was negative. FNAC is negative for malignant cells, suggestive of granulomatous lymphadenitis. Anti-tubercular treatment was started according to the fixed drug regimen. Patient was advised for the follow-up after 2 weeks. Sorry, sir. After 2 weeks of treatment, on examination, child was electric and liver was palpable 4 centimeters and total bilirubin, SGOT, SGPT, alkaline phosphatase, and GZT was increased. And liver spleen size was increased from 4 centimeters to 6 centimeters. RFT was normal. LDH is normal. Ultrasound neck shows cervical lymphadenopathy, and ultrasound abdomen shows splenomegaly. At this point, we first thought it could be iris, but since we had increase in size of spleen, we wanted to rule out malignancy, so we planned for excision biopsy. On excision biopsy, tissue CBNAT is negative for tuberculosis, and histopathological examination shows suggestive of Hodgkin's lymphoma. ATT was stopped and planned for immunohistochemistry for further prognosis. HPE slide of excisional biopsy of cervical lymph node shows scattered among lymph node. There are mononuclear Reed-Steinberg cell. There are occasional classical Reed-Steinberg cells. Granulomas have been well recognized histologically as discrete nodules composed of epithelioid histiocytes or multinucleated giant cells that are commonly accompanied by small lymphocytes. The underlying mechanism of granulomatous changes in Hodgkin's lymphoma remain unclear. Recent studies have provided possible mechanisms for granulomatous changes in Hodgkin's lymphoma are T cell mediated non-specific inflammatory response, Th1 cell mediated immune response to tumor antigens, delayed hypersensitivity associated with cytokines, continuous stimulation of tumor antigens. The differential diagnosis of this disease should be emphasized carefully. Tuberculosis infection nodules are usually characterized by irregular shapes with more Langerhans giant cells and typical caseating necrosis. It can also be excluded by acid-fast staining and negative detection by PCR. Sarcoidosis represent epithelioid granulomas forming nodules that are widely distributed in lymph nodes, accompanied by fibrotic nodules formation. Sarcoidosis often present as multiple systemic involvement and more commonly found in bilateral hilar lymph nodes. Epstein-Barr virus infection mainly manifest themselves with significant expansion of intrafollicular area and hyperplasia with lymphocytes with high pleomorphism and often occur in children and adolescents. The cells exhibit plasmacytoid reaction and Reed-Steinberg-like cells are also observed. Lennart lymphoma is a type of T cell lymphoma that in which Lennart lymphoma and Reed-Steinberg cells are also present. Immunohistochemistry differentiates its diagnosis from Hodgkin's lymphoma. Granulomatous, and my conclusion is granulomatous lesions can mask lymphomas. A high, a high suspicion is required with lymph node granulomatous lesion to avoid misdiagnosis leading to delay in treatment.
Recording in progress.
This case is mainly presented to create awareness in our country, like here where the tuberculosis is very endemic. Our first diagnosis is always tuberculosis. Here the FNAC was misleading, and after starting the anti-tuberculosis drug, the child had developed due to the anti-tuberculosis drug. So the increasing size of spleen, liver made us suspect that we are missing some other diagnosis. So we had to do an excision biopsy for a definitive diagnosis. Hence, we are able to catch the child earlier for the chemotherapy. Thank you.
Thank you for the excellent presentation. As we had previously, what we had taught and what we were taught was that common things are always common. So always we are, as Madam correctly said, we'll always looking for TB, because in our setup TB is more common. But nowadays, what PGs or the others should aware of is that whenever there is a dilemma, better going for excision biopsy rather than depending upon the FNAC. Sometimes we may miss the diagnosis or miss the bus, so that we can start early treatment. And we have to rule out also sarcoidosis. Nowadays, a lot of patients coming with generalized lymphadenopathy and with increasing ACE enzyme levels. So always excision biopsy is one thing which can clinch a diagnosis, and so that we can we will not miss anything, so that we can start treatment early. Thank you, Madam. Thank you for your wonderful inputs, Madam.
Maybe what learning point you want to convey, Doctor, from this? Like how to not miss lymphoma? Dr. Raghuram, are you there?
Dr. Raghuram?
Dr. Raghuram, are you there? Like, what take-home point do you want to suggest? Like, how not to miss lymphoma in this case? Okay, so maybe my suggestion is like, since we didn't get a diagnosis with FNAC, so maybe we can rule in, suppose a TB diagnosis was there, then we can rule in and treat TB. But if we don't get a diagnosis in FNAC, we don't get a diagnosis of TB, the CB-NAT didn't come positive. So better we go for the next step of excision biopsy, as Sir said, rather than empirically treating with ATT. I feel that might have been better.
Since we had a case with MAN2 positivity and all this FNAC, suggestive of granulomatous inflammations, and with the increase in AC enzyme levels, you are put in a dilemma whether to start ADT or wait for further workup, all these things. So, but ultimately the clinching diagnosis is excision biopsy and HP evaluation.
No other questions? We can move on to the second topic.
Yeah, next presentation is from Chettinad Hospital and Research Institute, presented by Dr. Priyanka on crisis and crash, how to manage. Moderator is Dr. Sujata Sridharan, Professor, Department of Pediatrics, Chettinad, and Dr. Navina, Assistant Professor.
Good afternoon, everyone. Am I audible?
Yes, please proceed.
So I'll be discussing a case of crisis and crash and how to manage. My moderator is Dr. Sujata Sridharan and Dr. Navina. So coming to the case details, Hemkrish, 5 years old male child hailing from Kedambakam, informant his mother, whose reliability is good, was brought with complaints of cough and cold for 2 days and complaints of fever for 2 days and complaints of vomiting for 1 day. A little bit about the back history of the child. He's a third born out of a third-degree consanguineous marriage. The first child being a girl child who weighed 1.5 kgs at birth, died at 10th day of life due to an unknown cause. And the second child being a boy child, weighed 1.9 kgs, died at 4th day of life due to vomiting, fever, and seizures. And this is the current child. So antenatal history for this child was uneventful. Talking about the neonatal details, this child was a term 38 weeks plus 1 GA. Previous LSCS, birth weight of 2.660 kgs and cried immediately after birth. Neonatal details, 2 previous sibling death evaluated on day 2 of life, developed metabolic encephalopathy in the form of subtle seizures, abnormal odor and sweaty feet. So the common features in the newborn period for IEM are refusal to feed, vomiting, metabolic acidosis, dehydration, hypoglycemia. So out of these 5 symptoms, our child had the initial 4 symptoms. So next we are going to look for ketosis and if there's skin manifestations or not. If there are skin manifestations, we can suspect multiple carboxylase deficiency. No skin manifestations, we have to look for the odor. No odor is seen in methylmalonic acidemia and propionic acidemia, whereas characteristic odor is seen in maple syrup urine disease and isovaleric acidemia. And if there's no ketosis or mild
Dr. Priyanka, your slides are not moving.
Sir?
Your slides are not moving. Just check.
Okay, so 1 second. Is it okay now, sir?
Just wait. Yeah.
So in the newborn period, we have advised parents to do a TMS and GCMS. TMS
Will it be
was
okay
done.
to continue from the previous slide because that was missed?
Okay, ma'am. So the common features in the newborn period are refusal to feed, vomiting, metabolic acidosis, dehydration, and hyperglycemia. So out of these 5 symptoms, the first 4 symptoms were present in our child. So we suspected IEM, and then we look for ketosis. If there is ketosis, we have to look for skin manifestations or no skin manifestations. If skin manifestations are present, multiple carboxylase deficiency, we have to suspect. And if there's no skin manifestation, we have to look for characteristic odor, whether there's or no odor. If there is no odor, look for methylmalonic acidemia and propionic acidemia. If there's characteristic odor, we have to suspect maple syrup urine disease and isovaleric acidemia. And if there's ketosis or mild ketosis, then we'll have to suspect acyl-CoA dehydrogenase deficiency and HMG-CoA synthetase deficiency. So we had advised the parents to do a TMS and GCMS. So TMS we did, which we found the values of isovaleric glycine was found to be elevated, which was around 15,000 range, and GCMS, which showed elevated isovaleric glycine levels of 27,000. So the child was diagnosed in neonatal life to have isovaleric acidemia. And the child was started on IV fluids, carnitine, biotin, and L-arginine supplements were started, and child was advised gluten-free formula feeds. NST USG was done, which was found to be normal, and fundus examination was normal, and thyroid profile was also normal. Coming to the past history, at 1 year, 10 months of age, child was admitted in CHRA for acute metabolic crisis. The child had vomiting, loose stools, dehydration for 2 days. The child did not have any shock, and electrolyte balance and hyperammonemia was present. So metabolic specialist opinion was advised, and they were advised genetic testing, avoid diet rich in leucine, non-vegetarian diet, milk and milk product. Metabolic nutritionist opinion was obtained, where they were advised meta-nutrition, which is an leucine-free meta-nutrition IV 2 scoops in 100 ml of water twice a day, and diet chart was given for the child, and carnitine was started at a dose of 100 mg per kg per day, and glycine 200 mg per kg per day. So coming to the developmental history, appropriate for age, good scholastic performance, and immunization history, immunized up to date as per national immunization schedule. So the growth parameters on admission here at 1 year, 10 months of age, the child was found to have severe acute malnutrition, where after that diet chart was given and supplements were started for the child. And at 2 years, 3 months, the child was on follow-up. We found the child to have moderate acute malnutrition. This child comes under moderate acute malnutrition at 5 years of age now. So history at current admission, child presented now with complaints of fever for 2 days, and cough and cold for 2 days, which was dry in nature, and vomiting for 1 day, 5 to 6 episodes per day containing food particles. Under initial assessment, the airway was pained and maintainable, and breathing respiratory rate at child had 46 per minute, tachypnea was present, and circulation, child had tachycardia, peripheral pulses were feeble, and CRT was approximately 4 seconds. The child was in compensated shock. And coming to the general examination, there were signs of dehydration, tongue was dry, eyes sunken, drinks poorly, skin pinch goes back slowly. Head-to-toe examination, other than signs of dehydration, the other head-to-toe examination was found to be normal. Systemic examination, all system examination was unremarkable. And on admission, we did an ABG, which showed metabolic acidosis, and CBC showed hemoconcentration, CRP was reactive, and serum electrolytes was normal, calcium, magnesium was also normal, and RFT showed pre-renal AKI. So child was managed accordingly. Child was managed according to the metabolic crisis protocol, that is British Inherited Metabolic Diseases Group. So the following tests should be done in a case of IVA, pH and gases, glucose, urea, electrolytes, calcium, phosphate, CBC, lactate, and blood culture. We were not able to do blood spot, acyl carnitine levels, and ammonia because of cost issues. And amylase and lipase, the child did not have any signs or symptoms of pancreatitis, so we did not do that. Urine ketones were found to be negative. So management in a case of IVA, we have to assess the clinical status. If the child is relatively well, then you can go on with oral fluids. If the child is obviously unwell, then we'll have to go on with IV fluids. So in our case, we started the child with IV fluids. So coming to oral fluids, electrolyte should be added to the drinks if vomiting, diarrhea is a problem, using standard rehydration mixtures following manufacturer's instruction, but substituting glucose polymer solution for water. So medicines, glycine should be given at a test dose of 300 mg per kg per day in 4 divided doses, and carnitine is normally added at a dose of 100 mg per kg per day in 4 divided doses. So the child was admitted with acute metabolic crisis with compensated shock, and the child was treated according to the BIMDG. Child was given, according to that protocol, we are supposed to give 2 ml per kg of 10% glucose over 5 minutes. And after that, we had given NS 10 ml per kg as a bolus immediately after the glucose. So we calculated the deficit and maintenance and prepared the IV fluids, and 0.45% saline was given. Carnitine was given orally, IV is also available, and 200 mg per kg per day in 3 divided doses we had given, and oral glycine was given. So after stabilization, as you can see, the pH was 7.290 and it improved to 7.385 at 40 hours post-admission. Lactate was also found to be in a decreasing trend, and AK had resolved at 40 hours post-admission. So in view of cough and fever, chest X-ray was taken. It showed bilateral minimal hilar infiltrates, and chest was clear on auscultation, suggestive of viral LRA, and the child was treated symptomatically. So coming to the discussion, isovaleric acidemia is an autosomal recessive inborn error of leucine metabolism, which is caused by a deficiency of the mitochondrial enzyme as isovaleryl-CoA dehydrogenase, resulting in the accumulation of derivatives of isovaleryl-CoA. So the goals of therapy is prevention. So first goal of therapy is prevention of metabolic decompensation. During times of metabolic stress, that is during illness and fasting, endogenous leucine from protein catabolism adds significantly to the production of isovaleryl-CoA. Achieving anabolism is the main therapeutic approach. Thus sick day precautions for patients with IVA should include increased caloric intake in addition to decreased leucine intake. And coming to the second goal of therapy, long-term reduction of the production of isovaleryl-CoA from leucine catabolism through dietary manipulation. And the third goal of therapy is to prevent the accumulation of toxic metabolites by shunting isovaleryl-CoA towards reactions that produce metabolites presumed to be non-toxic and that can readily be excreted. So basically, a diet low in natural protein and a formula that does not contain leucine has to be advised for the child. So coming to the glycine and carnitine supplementation. So why glycine and carnitine supplementation is that it binds to the isovaleryl-CoA in the cells, producing isovaleryl-carnitine and isovaleryl-glycine. So they leave the cells and the kidneys eliminate them in the urine. As a result, the body loses carnitine. This loss is replaced by supplementing with both carnitine and glycine every day. So how to educate the parents? So foods allowed and foods which are to be avoided. So foods allowed are cereals and grains, vegetables such as broccoli, green beans, cauliflower, fruits such as apples, oranges, apricots, berries, cherries, and foods to avoid are milk and milk products, meat and poultry, fish, eggs, nuts, and peanut butter. So coming to the summary, what is IVA? It is a disorder of leucine metabolism, and the optimal management is diet low in natural protein and IVA formula without leucine. Early and effective management of metabolic crisis during illness. Pharmacological treatment with the use of carnitine and glycine. So management result with proper early intervention, the child can have a normal intellectual and neurological development. And follow-up laboratory test includes special tests, routine tests, and in every OP visit, body height, weight, and head circumference are to be measured. And psychomotor development is important. Then management in case of developmental issues. So developmental delay, neurological symptoms, movement disorders, psychological and intellectual deficits, managed metabolic crisis can result in brain damage. So management is very important, and early intervention can lead on to decrease morbidity and mortality. So take-home messages, any child in the neonatal period suspected to have IEM, better to advise TMS, GCMS, and genetic testing. Because early intervention, it leads to better outcome and decrease in morbidity and mortality. Thank you.
Thank you, Dr. Priyanka, for your excellent presentation, which was followed from newborn period to the childhood, and
Thank you.
excellent workup. And thank you for the excellent, wonderful work done by the moderator. And
thank you, sir, and thank you, Priyanka. It was a wonderful presentation. And the presentation in newborn period was just a poor refusal of feeding, or any other presentation or the seizures was there?
No, sir, there was no history of seizures in the child, sir. No, refusal of feed was there, and child had metabolic acidosis and sweaty feet was there, sir.
Oh, okay. So at that time itself, we have diagnosed. So any idea how was the TMS report? Did you see what was elevated in that?
Isovaleryl glycine was elevated,
Yeah.
sir, for the child.
So, yeah, that we understand. But C1, C2, C3, C4, C5, like that, it will be there, no? Usually, isovaleric
C5 was actually elevated.
correct. Yeah, very good. So that is C5. Yeah. So mostly, isovaleric acidemia in TMS report, if you see that C5, that acylcarnitine levels are elevated. Good. So subsequently, I
Yes.
think you have managed well.
And how did you procure that meta-nutrition supplements and all?
So actually,
Yeah.
Sir, I
from
would like,
pharmacy, it was available.
Oh, okay. So in
sir,
pharmacy.
actually, Meta Nutrition, sir, I'm
Yeah.
Dr. Navina.
Yes, ma'am. Yes,
Good
ma'am.
afternoon,
Yeah.
sir.
Good afternoon, ma'am.
So
Yeah.
actually, Meta Nutrition IVA is specially formulated powder for isovaleric acidemia children. So it's according to age groups, sir, up to 0 to 3 years and 3 years and above. So usually we get it from the pharmaceutical companies, Pristine Pharmaceutical. And initially, because this child was on follow-up with the metabolic specialist in Ramchandra and with us, sir. So
Okay,
primarily
ma'am.
we are only taking care of the child. And initially, because they are from a little lower economic background, initially they could afford only one-time meta nutrition. So the
Okay,
cost
ma'am.
itself is around 1,000 to 2,000 rupees. So they could not keep up
Yes,
with
ma'am.
that. So that is why from Sam he's come to ma'am, but we're just managing him with general diet itself. So still
Yeah. Yeah.
glycine and carnitine we are procuring for them, sir, but not the
Okay.
powders. That's not available in our hospital.
Yeah, yes, ma'am. Yes, ma'am. Thank you, ma'am. Thank you, ma'am. And I would congratulate you to maintain the nutrition of the baby because no seizures or no much metabolic compensation for almost crossing infancy period and all. So nutrition, how did you manage, ma'am, for that low lysine? Any special nutritionist is there who can calculate the lysine levels and all, ma'am? That will be, that was very wonderful.
Basically, we have
Yes, ma'am.
just told him because he started off from a toddler age. Now he's in LKG going on to UKG, sir. So we gave the mother a chart like these are the things to avoid, these are the things you can give. So basically, lot of cereals you can give, but we should avoid certain type of millets and ragi. But the other things you can give because we cannot eliminate leucine completely from diet because
Yes,
it's
ma'am.
there in literally every food nutrition. So that's why he is also on continuous glycine and carnitine. So with that, we are able to maintain a balance, but he is still underweight only. But developmental wise, we are actually happy. He had some
Yeah,
mild delay in the beginning, but now he's actually caught up. He's going to a regular school itself.
that's
We
great.
are awaiting a formal IQ assessment for him,
Yes.
just to see which status he's in.
Yes, ma'am. Yes, ma'am. That would be great, ma'am. And as you told, so leucine-rich food we will have to avoid, and that diet chart that we have to follow. That is a very strict. Uh,
Yes, sir.
yes, ma'am. Thank you, ma'am. Thank you, ma'am.
First 6 months breastfeeding was not given, ma'am. Only formula feed. This special feed only was given.
Actually, we didn't meet the child till 6 months of age. The first presentation was about 1 year of age, sir.
Okay, ma'am.
Through history, the mother has told like at that point meta nutrition also was given. She was also giving breastfeeding, so it was not like it was completely eliminated from his diet. So I think mother was also counseled to reduce little bit of uh, her leucine rich foods, but you can't actually prevent leucine from not coming into the breast milk. It will
And,
definitely come,
and what
but
what is
thankfully he's
what is recommendation for pulses, ma'am? Pulses also you avoided or you are
no,
giving?
sir. We are actually recommending like basically what we did was all these protein rich chana dal and all those peanuts everything we told them to avoid, but for some calorie and to put on weight we told like you can have rice, wheat, even varagarsi which is very low in leucine, so it's lowest in among all the cereals. So we are recommending certain things. So initially he had some food fads like he was preferring only some over the other, but now because he's a little older child we're able to actually manage him. He's even eating raw vegetables itself, so he's
So
got a little
no
weird.
dal, no dal and all, man. Sambar and all.
No sir, only no sir, in sambar mother doesn't give sambar, she gives chutney only to the child.
Okay, okay, good, ma'am. Good. And like all infections, minimal infections, they worsen or any specific reason why now he worsened?
Actually, we're not sure about that because our hypothesis is till 4 years of age, he had only one crisis admission. So after 4 years, 5 years, he had two admissions. So maybe because he's requiring more metabolic thing, he's running around playing, that also puts him under more risk of infection. Second thing is he started attending school. So that also, he got admitted twice in this year itself. So both times a 48-hour admission with dextrose and saline, that actually helped him and became better. Mother is actually well trained in giving ORS and glucose, but both the admissions he admitted with vomiting. So that was his primary problem. So we had to give him IV for that.
Okay. Very, very interesting case presentation, ma'am. Thank you, ma'am. Thank you.
Thank you, sir.
If anyone else has any questions, otherwise we'll proceed on to the next presentation from Dr. Kamakshi Memorial Hospital, presented by Dr. Sri Pooja Bora Venkat on acute abdomen, the Meckel puzzle. The moderator will be Dr. Prahada, pediatric consultant, Dr. Kamakshi Hospital. I think their pediatric surgeon is also available. He has also joined, Dr. Arun, for his
Yes, ma'am.
insights.
Hello.
Yeah, hello, doctor. Good afternoon, sir.
Good afternoon. Thank you.
Good afternoon, everyone. I'm Dr. Sri Pooja from Dr. Kamakshi Memorial Hospital, Chennai. Today, I shall be presenting on acute abdomen, the Meckel puzzle. A 11-year-old male child presented to our PER with complaints of abdomen pain, vomiting, and fever. The abdomen pain was for 1 day duration, followed by vomiting, which was 5 to 6 episodes of non-bilious, non-bloodstained, and non-projectile vomitus. He had a high-grade fever not associated with chills and rigors. There was no history of similar episodes in the past. He was the firstborn child to non-consanguineous parents. It was a full-term pregnancy, delivered vaginally. Birth weight was 3 kg. The child had no history of NICU admissions. Developmental milestones were attained at appropriate age, and he was vaccinated up to age according to the National Immunization Schedule. There was no significant family history. On physical examination, the child was afebrile. There was tachycardia, good pulse volume, and the peripheral pulses were good. Systemic examination, on examination of the abdomen was distended, noted with tenderness in the epigastrium, right hypochondrium, and the right iliac fossa. There was guarding with no rigidity. The bowel sounds were sluggish. There were no distended veins, scars, or sinuses. No visible peristalsis was observed. The genitalia circumcised and bilateral testis descended. Other system examination was normal. A differential diagnosis of acute appendicitis was considered, followed by pancreatitis, cholecystitis, and hollow viscous perforation. Ultrasonography was done, which showed mild hepatomegaly with periportal echogenicity, edematous gallbladder wall, and moderate echogenic free fluid in the abdomen and pelvis, likely suggestive of peritonitis. The following investigations were done, which showed leukocytosis with neutrophilia. The child had elevated CRP of 198, and coagulation profile was delineated with increased PT and INR. Amylase and lipase were within the normal range, ruling out pancreatitis most likely. CECT abdomen was done, which showed mild particulate ascites, dilated small bowel loops, thickened omentum, and normal solid organs. You can see in the image that the contrast was not going through fully and only partially filled, which was suggestive of some sort of small bowel obstruction as well. The impression was of likely peritonitis or ileus. Initially, the child was managed in the emergency room with normal saline bolus and further treated with injections of trioxone, metronidazole, and other supportive measures. After stabilizing the child and investigations being done, in view of acute abdomen with peritonitis, a diagnostic laparoscopy was also planned. In the diagnostic laparoscopy, the findings were free fluid, which was purulent in nature in all quadrants. There was also pus in the pelvis. Dilated small bowel loops were noted. The appendix was found to be normal, and a Meckel's diverticulum perforation was found at the base. The diverticulum was noted at 45 centimeter proximal to the ileocolic junction, and it was delivered outside via a 10 mm port after minimally extending the incision. 2 centimeter from either side of the segment was resected and sent for histopathological examination. Thorough and adequate peritoneal lavage was given, and ileal anastomosis was done. Here's the image of the segment which was resected and sent to histopathology. Postoperatively, we escalated the antibiotics to injection meropenem. For pain management, the child was given injection fentanyl. Chest physiotherapy was initiated. On postoperative day 3, the child was started on clear liquids. On day 4, the NG tube was removed and we started the child on soft diet. Subsequently, we removed the drain tubes and mobilized the child. The child recovered uneventfully and discharged on oral antibiotics. Here's the image of the histopathological examination. So microscopically, you can notice the intestinal mucosa. It is a true diverticulum as it comprises of all 3 layers. In the lamina propria, you can see lymphoid follicles with adjacent mucosal erosion, edema, hemorrhage, and inflammatory infiltration. This is well observed in the first slide also, where you can see hemorrhage and inflammation with neutrophils. The impression was suggestive of Meckel's diverticulitis. A final diagnosis of perforated Meckel's diverticulum was made, followed by generalized peritonitis. Coming to discussion, so the omphalomycentric duct, also known as the vitellointestinal duct, connects the yolk sac to the primitive midgut. So we have a group of entities known as the omphalomycentric duct anomalies, which occur due to failed resorption of the omphalomycentric duct. These are of different forms and they include Meckel's diverticulum, omphalomycentric fistula, a fibrous band or a cyst, and sinus or polyps. Here I have attached the images of the same. So if the vitellointestinal duct is patent, you can see fecal discharge from the umbilicus. The second type is Meckel's diverticulum, as was noticed in this case. An enterocystocele, a fibrous band, a remnant of vessel, umbilical cyst, all these present as masses in the umbilicus, also an umbilical polyp in the end, which also presents like a mass. The Meckel's diverticulum is the most common congenital anomaly of the gastrointestinal tract. Most patients are asymptomatic. There is ectopic gastric mucosa which secretes acid, resulting in GI bleeding and abdomen pain, and they can present with unexplained anemia. So the types of ectopic mucosa can be pancreatic, gastric, neuroendocrinal cells, or a combination of the above. Painless rectal bleeding is the most common symptom. Pathophysiology. So the ectopic gastric mucosa, which secretes an acid, usually not neutralized by bile, and causes the ulceration of the adjacent normal intestinal mucosa, leading to painless bleeding. The site of ulceration and bleeding is usually at the junction of the diverticulum and the normal ileal mucosa and not present within the diverticulum. Meckel's diverticulum follows the rule of 2's, which is it occurs in 2% of population. It is 2 inches long, located 2 feet proximal to the ileocecal valve, and have 2 types of mucosal lining. 2% are symptomatic, and males are affected twice as often as females. To evaluate, there are non-invasive and invasive methods. Non-invasive methods include Meckel radionuclide scan or the Meckel scan, which is the most sensitive method. Here, technetium-99 is injected, which is usually absorbed by the gastric mucosa, and visualization is possible as there is ectopic gastric mucosal uptake. Second option is CACT of the abdomen and pelvis, which could show evidence of inflammation or obstruction at the site of diverticulum. Third option is capsule endoscopy, and invasive methods include diagnostic laparoscopy, as was done in this patient. Management, surgical excision via laparoscopic or open method. So the diverticulum should be excised along with a small segment adjacent to the ileum to include the ectopic mucosa. If significant blood loss has transpired, then blood transfusion must be done. Complications. So the most common complication of the Meckel's diverticulum in children is painless rectal bleeding, which can be occult or overt, resulting in anemia. The presence of a fibrous band, if attached to the diverticulum, can cause small bowel obstruction. It can also act as a lead point for intussusception, and the child can present with recurrent intussusception. Inflammation at the diverticulum can also cause Meckel's diverticulitis with perforation, as was seen in this case. To conclude, the most common congenital anomaly is Meckel's diverticulum. It is mostly asymptomatic. Painless rectal bleeding is the most common symptom, followed by unexplained anemia. Meckel's scan is the gold standard for diagnosis. Diverticulitis must be suspected when a normal appendix is found with a background of peritonitis. Resection with ileoileal anastomosis is usually the treatment of choice. Thank you.
And thank you once again for the excellent presentation from Kamachi Memorial by Dr. Sri Pooja. Dr. Arun, do you have anything?
Yeah, hello, sir. Yes, sir. The main reason that we wanted to present such a case was actually the common things are common. So any acute abdomen, the first thing which we always think of is when the peritonitis happens, we think it is always going to be appendicitis. So that is the most commonest thing. And this was also such an important condition where we presented with only acute abdomen with guarding and rigidity, and CT scan also was very, very inconclusive. CT scan we did not give us a clear-cut picture of appendicitis. So we had that one small doubt on seeing the CT scan that one half of the bowel loops were not completely taking up the contrast, particularly the oral contrast. So which gave us a clue that probably something else is going on there apart unusually than the usual than the regular thing. So it doesn't look like appendicitis to us. So probably we might have to have a band or Meckel's diverticulum was our thinking before even going in. So the one first point I wanted to stress to all the postgraduates and who are listening to us, we have to read the CT scan ourselves and we have to take all the clues. Don't just read the reports alone. So please do see the films. Films give us a lot of information than whatever what we can read from the reports, the words which say. So please learn to read the X-rays and CT scans, which are very, very crucial in this case, and always expect the unexpected inside. So once we opened inside, we saw the appendix was completely normal. And when we had to, the dilated bowel loops of everything was negotiated, and we are able to identify the Meckel's diverticulum. And once we identified the Meckel's diverticulum, we gave a complete wash around there inside, and we extended minimally the umbilical port. And with a laparoscopic assisted procedure itself, we were able to complete resection anastomosis, like you saw in the picture which Dr. Pooja shared. So this is all the any kind of peritonitis with such a kind of full of purulent abdomen also can be managed in a minimal invasive way. Is another point I wanted to stress here. And so these are the main two important points I wanted to stress in this one. And any acute abdomen is not always appendicitis, and it can be other things also. And in case of any band which is present, definitely obstruction can also happen in the same. That's all from my side, sir.
There is a question in the chat. Dr. Alexander sir has asked, is there any particular age at which that they commonly get into complications, the Meckel's diverticulum?
Not particularly, sir, not particularly, but usually the common age which we see is 2 to 5 years of age. So this is the common area of age group we get to see the complications. I think it is particularly relating to the dietary change and the time where the children go to school, the constipation also. When I'm sure everyone will be seeing this in OPD. The constipation usually starts commonly from this 1.5 to 2 years of age to that early school going age groups. That is when they are not toilet trained properly, but their food habits and everything gets changed. So I have a personal, I don't have any evidence to support this, but constipation does add as a factor in this kind of.
Okay, sir. One more doubt. What is the utility of Alvarado score for diagnosing acute appendicitis clinically, sir?
Actually, we don't specifically use it. Actually, people can. It's been used before. I personally don't use any Alvarado scoring. More of a clinical examination and all the history that is actually more important than depending on any scoring per se. So the main thing I wanted to stress, particularly this since it's a pediatric meet, history taking is one of the most crucial part. I always wanted to stress to all my students and postgraduates. Don't think when there is a fever first and followed by abdomen pain that's going to be appendicitis. It can have an acute abdomen, but it most likely it's a medical cause. So in appendix, the always pain comes first, followed by the fever. So when you have 5 days of fever and 1 day of pain, and a child is having acute abdomen, most likely it is not an appendicitis. So every single clue from clinical examination history, everything has to be taken meticulously and properly, and all those details has to be paid attention to. Anything else, ma'am?
If anyone else has anything to discuss. Okay, then we'll move on to the next presentation from Sri Satya Sai Medical College and Research Institute on rickets in CKD, renal rickets by Dr. K. Manigandan, moderated by Dr. Murali.
Good afternoon, everyone. I'm audible.
Yes, you're audible. Please proceed.
Good afternoon, everyone. I'm going to discuss a topic on renal rickets. Wait a minute, there's a problem here. A 13-year-old male child, second born to non-consanguineous married couple, was brought by mother whose reliability is good, came with the complaints of knee pain and knock-knees for 6 months. A child was apparently all right 7 months back and is a known case of CKD, after which he developed difficulty in walking, which was gradually progressive and associated with pain. There is no history of trauma, limb weakness, delayed dentition. There is no history of decreased urine output, no history of increased frequency of micturition, no history of abdominal pain or flank pain, no history of vomiting or loose stools. Past history, child had 1 episode of seizures at 8 years of age, treated with sodium valproate. Family history, born to a non-consanguineous married couple. No history of similar complaints in the family. No family history of hypertension, TB, or epilepsy or asthma. Treatment history, child was taken to Chengai Government Hospital 2 months ago in view of difficulty in walking. Relevant radiological investigation were done. Serum creatinine was done and found to be 4.70 and blood urea was 138. USG abdomen was done and found to have increased echoes on both kidneys. Echo was done and found to be normal. Injection erythropoietin 50 units per kg twice weekly is given. Nephrology opinion was obtained and advised fluid restriction of less than 1.5 liters per day and salt restriction 2 grams per day and tablet sodium bicarbonate, tablet calcium carbonate and tablet iron and folic acid, tablet vitamin C and tablet vitamin B complex given. Antenatal history was uneventful. The birth history, child delivered by NVD, term baby, cried immediately after birth. Birth weight was 3 kgs. Postnatal history, the no NACU admission. Child's developmental milestones are attained as per age, immunized as per age. On general examination, child is active and alert. Afebrile, pallor is present, and no icterus, clubbing, lymphadenopathy, sinus, and edema. Vitals are stable except the BP, which was a stage 1 hypertension, 129/83. Head to foot examination, frontal bossing was present in the head, and flat nasal bridge, and eyes or bilateral bited spot are present, and wide opened mouth and protruding tongue and dental caries are present. And upper limb, widened wrist and chest, no skeletal deformities, and lower limb or knock knees are present, and genitals are normal, and spinal back are normal. And systemic examination, shape of abdomen was normal, flanks was free, umbilicus normal shape, all quadrants moving equally with respiration, no swellings, scars, discharges, sinus as encouraged veins, and palpation, no local rise of temperature, no tenderness, abdomen is soft, no guarding or rigidity, no organomegaly. Inspection findings are confirmed. Percussion and liver span was 9 centimeter. Other system was normal. Investigation, hemoglobin was 7.6 and urea was 78 and creatine was 4.6 and ALP was 1011. And on ABG, it shows the metabolic acidosis. On X-ray, shows on wrist, it shows cupping and fraying was present. And in knees, it shows knock knees was present. CT hip and bilateral knee was taken. Irregularity of a metaphysis with the cupping and fraying with sclerosis and mild widening of metaphysis involving bilateral proximal distal femoral metaphysis was present and proximal tibial and fibular metaphysis present. And diffuse osteopenia, the impression was rickets, metaphyseal chondrodysplasia. In summary, a 13-year-old male child born to a non-consanguineous married couple was brought by a mother whose reliability is good with the complaints of knee pain, who is fully immunized as per age. It's a known case of CKD. On examination, frontal bruising, widened wrist, knock knees, and flat nasal breach was present. On discussion, the causes are vitamin D disorders and nutritional vitamin D deficiency, malabsorption, and decreased liver 25-hydroxylase, the calcium deficiency, the low intake, premature infants, malabsorption, and dietary inhibitors of calcium absorption. The renal losses are X-linked hypophosphatemia rickets and autosomal dominant recessive hypophosphatemia rickets, and increased FGF23, tumor-induced rickets, McAlpin syndrome, neurofibromatosis, Fanconi syndrome, distal renal tubular acidosis. And clinical features, failure to thrive, malnutrition, protruding abdomen, muscle weakness, fractures pathological or minimal trauma, head craniotapes, frontal bruising, delayed frontal closure, delayed dentition, and delayed dental caries. Chest, rackety rosary, Harrison grows present. Extremities, widened wrist and ankle, valgus or varus deformities, anterior bowing of tibia and femur, coxa vara, hypercalcemic symptoms are tetany, seizures, stridor, costopalaryngeal spasms. CKD-induced rickets, the serum calcium levels are normal or decreased, serum phosphorus is increased, PTH is increased, 25 hydroxyvitamin D is normal, 125 hydroxyvitamin D is decreased, ALP is increased, urine calcium is normal or decreased, urine phosphorus is decreased. The treatment with tablet sodium bicarbonate 500 mg at 0.8 mg per kg per day 6th hourly, tablet calcium carbonate 500 mg at 30 mg per kg per day, tablet iron 3 mg per kg per day and folic acid 5 mg BD, and calciferol drops 400 international units per 1 ml 4 ml OD. Injection recombinant human erythropoietin 200 international units and fluid restriction less than 1.5 liter per day and salt restriction less than 2 gram per day. Thank you.
Thank you. That was a nice presentation.
Actually, for rickets, what management was given? This child had rickets, na?
So sodium bicarbonate and calcium carbonate was given, sir.
Okay, so regarding vitamin D supplementation.
Yes, the vitamin D supplementation also was given, sir. Vitamin D and calcium.
No, but in this is chronic kidney disease, na? So the regular vitamin D will not work, na? So we have to give 1,25, na? Calcitriol. So did
Yes,
you
sir,
supplement calcitriol?
No, sir.
And any specific protocol for rickets management? Like the regular rickets, we have a protocol, na? So we give this much STOS therapy, or at least on a weekly basis, we give higher dose of vitamin D, no? For in renal rickets, anything of that nature you found out?
Sir, for vitamin dependent rickets, we'll give high dose of vitamin rickets, sir. Vitamin dependent is the type 2 will give.
Now, the regular treatment for rickets, na, we give on a higher dose, na?
Yes, sir.
So like that, you planned anything for renal rickets? Okay,
Yes, sir,
just look into it, pa. Chari.
Okay,
So your child is a 13-year-old male who has knock knees also, right? As per your examination, any plan for that? Any orthopedician opinion was sought?
Yeah, ma'am, orthopedic opinion was sought, and depends on the values of when the calcium and the value is reduced, they told, okay, we will look after the knock knees, they told.
Osteotomy has been planned. There is a plan for osteotomy.
Yes, ma'am. After 15 years only they plan for osteotomy. After 2
Okay.
years they plan.
Okay, the forum is open for discussion.
Hi, myself Dr. Naveen. What is the cause of CKD here?
Might be.
No, is it been screened? Like, is it
Metabolic
that-
acidosis, maybe metabolism.
okay, that is a
Bone marrow
complication due to
metabolism.
CKD.
Bone marrow
Okay,
metabolism.
okay, those are comorbidities. What you are telling, describing everything is comorbidities. Yes, your anemia, this is specifically, we don't call it as renal rickets. We'll call it as renal osteodystrophy or mineral bone disease. Okay. So you have to find out the cause of CKD first here, whether it is underlying any tubulopathies is there, any CACUT is there. So other things you have to, I think you have to screen. And we have done CT. Why we have done CT for this time? CT, hip and knee was done. Was it any other DD was there or?
Just knock knees was there, sir. So once on that.
Okay. Okay, fine. Yeah, thanks.
Okay, thank you everyone for joining for yet another interesting set of cases and academic discussion. Thank you, HODs of all the institutes, especially Dr. S. Subhash, our HOD, SRM Medical College, for chairing the session. Dr. Jayashree ma'am, Dr. Sundari ma'am, Dr. Suresh sir, Dr. Prahada ma'am, all for Dr. Alexander sir for joining today. Thank you all the faculties, all postgraduates. Thank you, Dr. Arun Prasad sir, pediatric surgery consultant, for joining and giving your insights. Thank you all the IAPNs who've joined today. Let us all meet for the next edition and continue the same academic discussions. Thank you, everyone.
Personally, on behalf of IIP Chengalpattu, again, I thank you. It was wonderful, actually. So now we are getting more cases, good quality cases, which is making us more interested. And there are even cases waitlisted. We had to waitlist, and we couldn't have a slot for ourselves. So such is the participation by all the colleges. We are very happy for it, and we will meet again next month.
And one more thing is whether this case is presenting here is discussed by the PGs or not, but the faculties are discussing about these cases. And this gives a valuable insight when we have encountering a new cases or without unusual presentations and all. So definitely it's one of yeah, learning platform for both faculties and also for PGs. So I ask every PGs and faculties to make use of this platform to share their knowledge on these things. And I thank you once again for all the HODs and all the faculties, IAPNs, particularly Alexander sir, Suresh sir, and Sundari madam, and Jayashree madam, and all the faculties and senior peoples here. Thank you once again.